Thank you very much, Nanny, for this very nice introduction. It's really a pleasure and a real treat to be here and to talk about cardiovascular manifestations of COVID-19. Why cardiovascular? Well, because in this very day and age, we think of COVID-19 as a primarily pulmonary disease, but research has actually shown that it is a vascular-centric disease, and therefore, by extension, we have conducted quite a few papers, quite a few research on cardiovascular manifestations as well. I will look at 4 major points in this talk, starting generally what we actually do at autopsies, how we look at hearts at autopsies, then carrying on with cardiovascular manifestations from a clinical point of view, and then moving on to our experience cardiopathologically, and wrapping up with long-term cardiovascular damage and long COVID-19. So in our modern day and age, we are living in a society which is very sedentary. We sometimes make poor dietary choices. And this has led to an increase of obesity and of high blood pressure and of various cardiovascular diseases. And therefore to a higher rate of death by cardiovascular diseases, not only in Switzerland, these are Swiss data, but this can be, of course, replicated in many developed countries. We see here in orange the most common cause of death in Switzerland by cardiovascular diseases, and also an increase of hospitalizations throughout the years due to these kinds of manifestations. Therefore, the heart is a very important organ to investigate at autopsy. We have a systematic approach where we look at all 4 chambers. We start with the right atrium and ventricle and go on with the left heart, as you can see here open here. We look at the valvular structures and we look at coronary vessels. We measure things grossly, such as thickness of the ventricles. And therefore, it is very important to look at the heart, since there are many autopsies which have valvular damage. This is actually a very common finding that we see. This is atherosclerosis. We see here the plaques, which are broken open. This is a severe atherosclerosis. We see this in majority of autopsies, but also myocardial infarctions. Here's like ischemic area, and diffuse thickening of the myocardial muscle, also termed myocardial hypertrophy. Now, why is this all important? When we started performing autopsies on patients with COVID-19 early on in the pandemic, in the first autopsy series, we already had noticed that the majority of our cohort was male, was overweight, and also had high blood pressure and atherosclerosis, and also diabetes. And what this graph actually shows really nicely, if you compare COVID-19 with other viruses, other coronaviruses, also influenza, and you look at the odds ratio of metabolic syndrome and all of the other manifestations, you see that there is about a 13-fold increase of odd ratio for cardiovascular disease versus influenza, for example. So very early on, we recognized this pattern. The spectrum of cardiovascular manifestations in COVID-19, just as with other viral diseases, is very heterogeneous, ranging from NSTEMIs or STEMIs all the way to newly occurring arrhythmias, as well as thromboembolic complications and heart failure due to the microvascular disorder. We see here that especially elderly and patients with cardiological comorbidities are especially prone to these presentation. Troponin T, as we all know, a very helpful clinical marker, elevated troponin T being a gold standard used also for looking at dynamics in cardiovascular ischemia, but also in myocarditis. And the same could be seen for COVID-19. So patients with myocardial injury, pictured in blue, were far more likely to receive mechanical ventilation, far more likely to develop ventricular tachycardia or ARDS in the course of their disease, and also more prone to have a lethal outcome. And if you extrapolate this on the concentration of troponin T in the blood, you see that there is a direct proportion between mortality and concentration, and also obviously the dynamics, which I had explained earlier, more likely to occur in lethal cases than in mild disease survivors. I would like to make this part of my presentation slightly more interactive and more understandable for those without medical knowledge who might be listening in. And I decided to present our findings by 3 real-life cases that we actually experienced in our clinic. The first one being an 84-year-old female. She is a cardiological patient. She has a 3-vessel coronary artery disease, a history of diabetes type 2 and hypertension. She presented with COVID-typical symptoms and with bilateral consolidations on X-ray, and was tested positive in due course. And she died pretty suddenly, very shortly after admission. She collapsed, and no treatment was initiated ante-mortem. Her heart actually had a normal weight, 255 grams for her gender and BMI. As previously described, she had an occlusion of all 3 coronary vessels. What was particularly interesting from when you look at the heart grossly was signs of hemorrhages, but also this area on the anterior wall. And if you did make a longitudinal cut, you would see a transmural perforation or rupture of the myocardial wall, and this is due to thrombotic occlusion of the left anterior descending artery. And this area, of course, denoting a slight discoloration around the perforation, which then histologically was an acute myocardial infarction, as evidenced by the neutrophilic granulocytes and the acute necrosis in the tissue. What was particularly poignant about this case was that in adjacent tissue, we did see a little bit of cardiac inflammation. You see here these little blue cells are a mixture of lymphocytes and macrophages and eosinophilic granulocytes. And in other areas of the tissue, we did actually see individual cardiomyocytes being necrotic. And if you did make immunohistochemistry, one would see this as a mixed inflammatory infiltrate composing of T cells and macrophages, CD68 we didn't show here for brevity. So this is a case of active lymphocytic myocarditis actually occurring concordantly with anterior wall infarction, both of which led to her cause of death. Second case I brought is a 47-year-old female who did not have any cardiovascular risk factors apart from obesity. She quarantined at home, and she unexpectedly passed away. She was found by her son. She was tested positive as well and had a very rapid decompensation within admission to the hospital. And here you see a similar picture to case 1. We see here the myocardial tissue, and we see a mixed infiltrate, inflammatory infiltrate composed of granulocytes and maybe also some macrophages, some lymphocytes here and there. And we also performed PCR on the myocardium, which turned up positive. So it's very consistent with SARS-CoV-2 associated myocarditis. In adjacent tissue, we found a few microthrombi as evidenced by the fibrin stain. So we see a pattern here, like with case 1, we see the thrombotic occlusion of the artery, the coronary artery, and here we see microthrombi. So this is the cause of death, the myocarditis. And for case 3, a 54-year-old male, somewhat contrasting to the first 2 cases, we have a moderately overweight patient with a history of atherosclerosis who presented with progressive dyspnea and a new arrhythmia, atrial fibrillation, which he never had before. He developed cardiac shock, was admitted to ICU, and required ECMO therapy in his course. However, succumbed to cardiorespiratory failure 14 days after admission. It's quite striking, really, this pulmonary findings. This is what we call an hepatization of the lung. Normally, lung tissue is very spongy, and here you see actually it's quite dense. It actually looks like liver tissue. There's areas that seem almost black, dark brown, which denote hemorrhage and infarction. And quite interesting, if you look at the hilar area, we see embolisms in both arteries and veins. And the histological picture actually does show very nicely that he did suffer from COVID-19. We have the classical diffuse alveolar damage, but also areas of bronchial pneumonia, which denote possible superinfection with something else. And sure enough, when we looked further, we detected fungal species. We did a fungal PCR, and it was positive for Aspergillus fumigatus, which was also angioinvasive. So this is COVID-19 associated invasive aspergillosis. Interesting, in the heart was far too heavy. It was almost 600 grams. It had eccentric and biventricular hypertrophy. And you can see also some histological signs of heart hypertrophy, also with some of the nuclei being way too big compared to others. And in other areas of the heart, we did find fungal species as well. So, and we also did find some in the kidneys. So all in all here, the cause of death is multi-organ failure due to disseminated Aspergillus fumigatus infection, due to most likely immunosuppression, right? But due to SARS-CoV-2, because he did not have any prior history of immunosuppression for other reasons. And the cardiac hypertrophy, which probably did not form within a day, is also a question mark. Why did he have this? Because he didn't have any other signs, symptoms. So maybe it was genetic, we do not know. So what these findings actually show us is that presentations at autopsies are quite heterogeneous, and we decided in due course to perform a systematic light microscopic analysis on 23 hearts with lethal outcome. And as we expected, our cohort was predominantly male, predominantly rather old, 76 years old, and also was overweight on average, unsurprisingly, with a high incidence of cardiovascular comorbidities. And we also diagnosed cardiac hypertrophy quite frequently at autopsy, and all patients suffered from atherosclerosis of the greater vessels. Histological features we could summarize in two main features that we saw. Firstly, light microscopic signs of microvascular dysfunction, as evidenced by stasis of capillaries and microhemorrhages in the tissue, but also, as I previously had shown, microthrombi and also thrombi in arterioles, greater vessels, as denoted by the positive fibrin stain. Anocytosis of erythrocytes. As you can see, the erythrocytes have different sizes and also are disfigured. As you can see here, these indentations here, these fibrin strands could be a sign of disseminated intravascular coagulation. The second histological pattern we saw was cardiac inflammation. Out of the 23 hearts, 5 showed signs of mixed inflammatory infiltrate, as I previously showed, and 1 patient with necrotizing lymphocytic myocarditis. That was the first case that I'd actually shown. And if we summarize this, and we did some correlation analysis, we actually found that those hearts that had higher viral load were more likely to be RT-PCR positive. So there was a positive detection of the virus in the myocardium, and those hearts seemed to have higher incidence of histological criteria, histological features of microvascular dysfunction, whereas hearts that rather had a negative, or where we couldn't find the virus anymore, had longer hospitalization times, but a higher incidence of cardiac inflammation. And what this probably denotes is that it does take a little bit more time until the virus does get eliminated, and cardiac inflammation is a secondary effect. We actually also looked at, we actually searched for SARS-CoV-2 with immunohistochemistry, and we did not find any positivity of immunohistochemically in the cardiomyocytes, but only in macrophages. In fact, twice the amount of macrophages were found in the heart than in COVID-19 patients than controls. And this also lines up with other papers. This actually shifts the focus, makes it interesting to see what role macrophages have in this subtype of myocarditis. Moving on, myocarditis itself, very complex pathophysiology, too much for me to go in here, but what's particularly interesting or important to mention in respect to coronaviruses is angiotensin II. So this is a receptor that is found in a cell membrane of many subtypes of cells, also including cardiomyocytes, but also of parasites and then of endothelial cells, much higher density, by the way, than cardiomyocytes. And ACE2 is used by SARS-CoV-2, but also by the previous SARS virus to get internalized. What is particularly noteworthy is that it also plays an important role in blood pressure regulation and actually has a vasoprotective effect, rather anti-hypertrophic effect. So if you internalize lots and lots of ACE2, you will have much less on the surface, and you rather would take away from this protective effect. And we did look at this at ACE2 in particular as well in our group, because very early on in the pandemic, there were actually questions from clinicians: are patients with antihypertensive therapy that specifically target ACE, are they at a higher risk of succumbing to severe disease? And very interestingly enough, we did find subtle differences between patient cohorts that took antihypertensive therapy and those who didn't. So those actually died earlier and had a higher viral load. However, these results should be interpreted with caution, because those, and this was the same cohort as the one with the hearts, those also were the ones who had more cardiovascular risk factors to begin with. So lots of more work to do in this area. Clinicians have caught up in the meantime and have actually refuted this theory, which was put into the scientific space in 2020. Are these antihypertensive therapies, do they predispose to a more severe disease course? And from a clinical point of view, this just couldn't be proven. So I'd like to wrap up with the long-term cardiovascular damage, which is probably my most important part of the talk, albeit short. We as pathologists do not get endomyocardial biopsies very frequently anyway, and much less likely from survivors of COVID-19 or from patients with long COVID. Actually, radiologists do much better at this. So this is a group from Frankfurt who specializes in cardiac magnetic resonance, and they performed two studies. The initial one in 2020, where they looked at a mix of in and outpatient COVID survivors, actually found out, unsurprisingly, okay, troponin T elevated in most of the cases, but 3/4 of all hearts that they scanned did find abnormal findings of magnetic resonance, so elevated native T1 and T2. And they followed up 2 years later. They took a greater patient cohort, and they actually focused more on mild disease outcomes. So actually, people like you and me that would quarantine at home and would not need hospitalization in the first place. And they looked at the heart about 100 and 300 days after COVID-19, and still they found evidence of elevated T1 and T2, especially in patients who still had symptoms, like maybe had tachycardia or dyspnea at that time. So this shows that there has to be something a morphological correlate with this long-term damage. Yeah, indeed, the spectrum of long-term cardiovascular damage is just as heterogeneous as the manifestations of COVID-19 themselves, and the excess burden, as had measured this study in comparison with a control cohort is actually quite immense. And when you look at those patients which were non-hospitalized, by the way, the colors green, non-hospitalized, and purple if ICU, then you do see that the overall any cardiovascular outcome still increased as compared to the control cohort. So a lot more to look at for long-term and long COVID disease. So in conclusion, overall cardiovascular manifestations are uncommon and heterogeneous, but still we see hallmarks of COVID-19 associated myocardial damage, such as microvascular dysfunction and cardiac inflammation. It is very important to add that the disease outcome is notably manipulated by a previous risk of cardiovascular disease, and we need to definitely focus and shift our research towards long-term effects. Thank you so much for your attention.